So I'm here to present the U.S. perspective and show you how really terrible I am at mechanics. Those are my disclosures. Funding through NIMH, the U.S. Substance Abuse and Mental Health Services Administration, and the AFSP has allowed me to do the work that I've done, and the Centers for Disease Control, and my other disclosures. Okay. All right, I should also say at the beginning, because it fits in so well with Abigail's talk, that I direct a center that's co-located at UCLA and Duke so that we can cover the country for trauma-informed adolescent suicide, self-harm, and substance abuse treatment and prevention. And for those of you who don't know the US system very well, NIMH funds research, SAMHSA funds services. And so the goal of this center is part of the National Child Traumatic Stress Network, which our government has decided that we should have centers around the country to address traumatized children. And our specific center focuses on bringing treatments and evidence-based care and collaborative work to improve quality of care and outcomes for kids who are struggling with suicide and self-harm, or are at risk for that. So a lot of what we're doing on a research side is being disseminated collaboratively with sites around the country, so I'm learning so much every day. So as Dennis said, I'm gonna focus on treatment and care delivery, I think Lars said that too, and nationwide suicide prevention, and focus on what we've learned from the special issue, which I think is really extraordinary if you look at the papers in there. So treatment. Let's think to begin with about what happens when a child comes in with suspected suicide or self-harm risk. So the first thing we do is we take safety precautions, right? We do not leave the child alone. We make sure that they're protected. If they've injured themselves, we provide medical care and clearance so that they're okay. And then we provide behavioral health care or consultation to the emergency team or the primary care team. In the US anyway, the main thing that they do in emergency situations, or we do in emergency situations, is we make a decision about whether someone needs to be in more restrictive care and needs to go into inpatient hospital as compared to whether they can go home, right? But the problem is that they don't get to outpatient care after they leave the emergency. Only about 50% of our kids, I don't know what the rate is here, but only about 50% of our kids nationally get to outpatient care. So if they don't get there, it doesn't matter what we do, it's not gonna help. And in some of our settings, the rate's as low as 20%. So we started out with what I call the Family Intervention for Suicide Prevention, or Safety Acute, which is an intervention that you can do in an emergency that's more than just deciding whether they need to go inpatient. And the goal of that intervention is to improve continuity of care, which is one of our major objectives in our national strategy for suicide prevention in the US. And secondarily, we want to increase safety, improve family support and protective monitoring, and improve youth functioning, of course, with the caveat that what can you do in one session? You can't do all that. You can hope to get them to care. So the approach that we've taken is different than standard safety planning. Do you guys do standard safety planning here regularly when you see them? It's really a little different because it's very developmentally informed. And what we do in the intervention is we think of it as a behavioral assessment. Just like in many medical problems like asthma, you give a little treatment, you see how people respond, and then you make a decision about subsequent care based on that. That's what our intervention does. We pose a series of challenges to the kid and see if we can drag out reasons for living. Hope, as Lars said, is so very important, whether we can get that from the kid in the initial intervention. And then we engage in developmentally informed safety planning, where we begin by helping the child to understand their emotions using an emotional thermometer tool, and look at how their emotions either shoot up really fast or gradually move up and hit a danger point, and what they might do, how they might feel, and what they might do at different levels of emotionality, so that they can then bring in coping strategies that work at these different levels. So at the hottest level, like Lars said, you want to get the dive reflex working or something to reduce the emotional temperature. And then in our intervention, we really focus very heavily on the family or some adults to increase protective support. You may have seen Cheryl King's recent data that showed that by mobilizing adults in the child's environment, she was able to actually reduce suicides and other kinds of deaths 10 years later, even though actually her short-term effects were pretty measly, right? So we would do a lot of, as Lars said, working on lethal means counseling, mobilizing the parents, because hanging, how are you going to get rid of all the ways you can hang, right? You have to get the parents to watch their child like you would a younger child. You have a young child, you don't leave them at home alone. If you have a child who's suicidal and self-harming, you don't want to leave them alone. If it can't be you, because you'll suffocate them and the kid will get worse, you want someone else there. You just don't want them alone. And then we follow it up with caring follow-up contacts to support linkage to treatment. And what we find with the intervention is we can get almost everybody to care. There's really no reason why our national rate should be 50%. We got 92% of them to care. And the 76% was with enhanced usual care. So if you just standardize care in an emergency department, you'll improve rates. But you can get everybody to care if you do an intervention to get them there. And so that suggests that we need to change our approach to usual care so that you do have some kind of therapeutic assessment. Maybe it's ours, maybe it's Dennis's, maybe it's one of the other ones. But there are treatments that work to get our rates of follow-up treatment better. Now here's the bad news. This is a complicated instrumental variable analysis, but I want to draw your attention over here. So here we have the effect of the intervention, the emergency intervention, and you can see we have a significant effect. Kids get to treatment. Treatment doesn't matter. That's what that shows. Getting them to treatment, this shocked me, made absolutely no difference. I thought having a caring, loving person to talk to would make a difference. It doesn't make any difference. In fact, they got a little worse. So where are we? And Lars started this discussion for us. So I'm going to refer to this wonderful meta-analysis that Dennis led, and I think our first collaboration, right? And we looked at all the studies that have been done through May 2014, and I think there's other people in this room probably who worked on that as well. It was a wonderful meta-analysis. And what we found is when you put together all the diverse interventions, and they're really diverse, you get a small statistically significant effect, but very small, on self-harm. So therapeutic interventions do make a difference, but it's a small effect. And then since then, and drawing a little bit from those studies, we have 3 randomized controlled trials that show that CBT with a strong combined individual and family component. Because remember, these are kids. First of all, their brains are developing. They don't have, their frontal lobes aren't really that strong that they can do it all by themselves. So it seems that having the family component seems to be very important. Those 3 studies, Lars's DBT trial, my safety trial, and Christy Esposito-Smithers' integrated CBT trial for kids who had both suicidality and co-occurring substance use problems, led to reduced suicide attempts. And as Lars said, we have 2 separate demonstrations now that DBT is effective for decreasing self-harm in adolescents. And a discussion we all have to struggle with is understanding, in the US, we're all looking at suicide attempts, and everywhere else they're looking at self-harm overall. I don't know what to do about that myself. I'm looking at both now, but I didn't originally. I'm American. I looked at suicide attempts in my early work, but you guys have taught me. And then I won't, this is Lars's wonderful study, so I want to make a point of saying that he was first. And then came the CARES trial, the Macaulay study that he's describing, that Lars described earlier. That was a 2-site study of dialectical behavior therapy And what we compared it to was individual and group supportive therapy that was matched to DBT for intensity of the dose that was offered. So it was really, it was pretty rigorous comparator. And we did this in Seattle at both University of Washington and Children's Hospital Seattle, which is these two pictures over there, or that picture over there. This is not a pointer. And then here's our new hospital at UCLA, and that's Harbor UCLA. So they're very different sites. We had a lot of diversity in the sample. So what we found, as Lars pointed out, is that we had a significant advantage for DBT that we saw at 6 months, and then at 12 months they came together again when we're measuring the number of suicide attempts. And as you can see, it was about 90% of our kids had shown remission of suicide attempts at 6 months at post-treatment. So that would be the period between mid-treatment and 6 months versus about 78.5% in the control condition. And I might say that the DBT we used was different than the DBT Lars has used. It was a longer DBT, it was 6 months, and it was Marcia's DBT. She was a PI of the study, it was her DBT. There is only one DBT. Now, where we saw the effect at 12 months, interestingly, was on what we called clinically significant change. And there we got and what that is remission of self-harm. So that was during that whole period after we withdrew treatment, did the kid engage in any self-harm? And there we found a significant DBT advantage at 6 months and then at 12 months. So that's where we seem to have our strongest effects. So I guess another question for discussion later might be something like, how do you figure out what your primary outcome should be? And then, importantly, I just want to remind everybody how terribly important replication is. So these are Christy Esposito-Smithers data in the blue. This is my attempt to make a slide, sorry guys. What she did is she adapted her original integrated CBT for co-occurring substance use and suicidality, and extended it and modified it a little bit and used a different population, and it didn't make any difference from usual care. It didn't seem to work as well. And those are my data from safety, where there's no pointer, huh? So where the top line is the likelihood of a suicide attempt, and it's very, very low in the safety condition, and the bottom of the line shows you that we have a 30% risk of suicide attempts over time in the control condition, which was enhanced usual care. So replication is essential. I need to find out if we can replicate that. I have no idea. Okay. Now the other question that we have to ask is, given that our treatments only work for some of the kids, can we personalize treatments and match kids to the treatments that are going to help them the most? And this is from the DBT trial, okay? And that just shows you something we found multiple times, that in the US, we don't have the NHS. We have a really inequitable healthcare system. And the Hispanic kids did much better than the non-Hispanic kids. And we found this in multiple studies. So bringing evidence-based treatments really makes a difference. So here's the exciting data. Okay, this goes to prevention really can save lives. So the Garrett Lee Smith program is a national program, kind of like the NCTSN, that's all over the country. And what they've done is they've mobilized communities around suicide prevention. And they've given all these grants to counties and tribes, because we have a very, very high rate of suicide deaths in some of our Native American populations. And what they found, I'm going to go to the next slide, is that if you look at the Garrett Lee Smith counties compared to the control counties, you see a marked reduction in suicide rates in the kids. These are death rates, not attempt rates. The attempt rates look similar. This is in the special issue, by the way. And the longer they have the trial, the program going, the stronger the effects. And look what happens when the program is withdrawn. The effect goes away. So what this really underscores is the importance of having sustained implementation of suicide prevention programs, and they really do work. They estimate that we had 882 deaths avoided, 882 lives saved of young people because we had the Garrett Lee Smith program in place. So that's wonderful, right? And then in Europe, you have the Saving and Empowering Young Lives in Europe study, where this is Danuta Wasserman and colleagues' data published in The Lancet, where kids who had the Youth Aware for Mental Health program had a significantly lower rate of suicide attempts over 12 months as compared to the others. So, and we have a paper in the special issue by Shira Barzilay and that team that looks at, within that trial, in the control group, who attempts suicide over 12 months. And it's the usual cast of characters: a previous suicide attempt, suicidal ideation, deliberate self-injurious behavior, non-suicidal self-injurious behavior, health risk behaviors, and suicidal ideation plus health risk behaviors, and suicidal ideation plus deliberate self-injurious behavior. And what's interesting is with the intervention, the effects of these risk factors tended to decline. So getting kids into care through the youth awareness of mental health problems, or even the question, persuade, refer, or screening and referral, led to these risk factors not being quite so powerful. So the take-home points are, we can identify kids at risk, as Lars said. We have lots of good screening tools now. In the US, however, they tend to focus on suicide, not on self-harm, so your data is really interesting and compared to ours. But we have to remember that screening is only good if we have resources available to take care of the kids, because if you screen the kids, we've heard, I'll never tell anyone again because they came with handcuffs and the police took me to the hospital. All my friends saw it. I'll never just admit it again. We have treatments that work. DBT has certainly been shown in the 2 RCTs to have an effect, and we have other treatments that have been shown to be effective in singles trials, and we'll have more data someday. While not every suicide can be prevented, we can reach for zero. That's a big movement in the US, the zero suicide. Do you have that here? Zero suicide, the aspirational goal of making it a never event. But the Garrett Lee Smith program, that's really encouraging data, because those are very diverse, but implementation is a challenge. So what does treatment have to look like? We identify high-risk kids, we link them to treatment, we mobilize therapeutic assessment or safety, FISP, to get them to treatment. And when they are safe for outpatient treatment, to use evidence-based outpatient treatments. And sometimes intensive community care is needed, and Dennis can talk about this later, and to avoid hospitalization, which can have an iatrogenic effect because they can learn. I'm going to run out of time. So we want to reduce access to firearms and alcohol and drug use. And we have a program that we've developed through our center where we're trying to develop a decision aid for parents to help them make decisions about how they're going to store firearms. We have such a big firearm problem in the US. It seems like every day something awful is happening. I'm afraid to turn the news on. And then the other bad thing that we have happening is media. So the 13 Reasons Why, I gather it was also been shown here, was a very engaging film, actually. I watched all the episodes, but it was horrible in so many ways because it really romanticized suicide and showed in graphic detail a suicide. I personally had a copycat suicide attempt in my clinic. It was almost identical to what was shown in the film. And we have data that shows that we had a 30% increase in the suicide death rate, in kids ages 10 to 17 after that release of 13 Reasons Why, in spite of the fact that our community mobilized to try to get them to stop it. And we had no impact at all. It was really awful. So in closing, I want to remind you of something Lars said, which is that the suicide rates do increase during adolescence. And what happens between childhood and adolescence? Well, our kids are really watched by their parents, right? That's my little grandson. He's on a glider. He has a helmet on. His parents are within inches of him to grab him if anything happens. And those are our teenagers, right? I mean, we know. Teenagers engage in risky things. Not all of them, but they do. And if you look at what happens with suicide, this is US data for ages 10 to 14, and what you can see is the rate of death by motor vehicle traffic injuries has reduced remarkably between 1999 and 2014. But what's happened with suicide? It's crossed over. We actually lose more children to suicide than we do to motor vehicle accidents. It's startling, and we have to do better. And my plea is that we engage families and communities to function like protective seatbelts and mobilize all those circles around the kid, the family, the community, the schools, the health systems, media and technology. They could do something other than these 13 reasons why. They could have 13 reasons why you should want to live or why not to kill yourself. So that is my plea, and thank you.